Hi, Liz. It's nice to see your face, guys. So, pakita naman kayo para hindi ako alone. Okay, so I think we can start with some housekeeping rules for this afternoon's forum. So, I'll just share my screen. Hold on a minute. Okay. So, I would like to officially welcome you to the first online forum for APAS. It's a little bit different than what we did last year, which was really a comprehensive lay forum. So today we will just be having 1 hour, and I'm very thankful for our doctors. I think Doc Guinto is already inside the meeting room and Doc Carol for agreeing to do this online forum. It will be very short, I know, but I hope that you get a lot from the answers that they will be giving to some of the more common questions that you would usually see in the APAS group. So welcome everyone. So just few of the ground rules that we have for this afternoon. Put all your audio on mute. I actually unmuted na din everyone. So again, please note that this short Q&A with our guest doctors is not a substitute to an actual consultation. And as you all know, and as what we have always emphasized within the group, is that all our treatments are personalized per patient according to your own medical history. So, iba-iba talaga yung treatments na binibigay sa atin. So, don't take this as something that would replace actual consultation with your medical practitioners. And lastly, of course, it's the same within the group na let's all be courteous and maintain positivity. And thank you so much for being here. So I'll just check lang the participants. Wait lang. We have 20 participants in Zoom room, and there's even more in Facebook. We have 40. So thank you guys for being here again. We have some of our APA sisters straight from Nueva Ecija. So there. So Doc Carol and Doc Guinto are already here. Hi, Doc.
Hello.
Ayaw mo pakita.
Papakita na ba? Okay.
Lonely ako eh. Hi, Doc.
Hello to everybody.
Okay, so I think we can start already. I'll go back to my screen. Hold on. Okay. Okay, so I'm officially welcoming our guest doctors for this afternoon. They're very dear to me. Of course, sila yung invite ko because they were the reason why I have Santi and Lucia. and pwede ko silang pakiusapan to the max. So I think this forum was conceptualized 3 weeks ago. So na-message ko lang si Doc Carol na, Doc, I was thinking of a webinar for APAS Awareness Month this June. And she said, oh, para tayong iniisip. So sabi ko, sige, game. So this happened, and I'm very, very thankful to Doc Carol and Doc Claire. I know they're very busy, and especially it's a holiday today. So yeah, without further delay, I'd like to introduce you to my two wonderful doctors who are here. I know they're not really new to you. You've seen their names in the group so many times. And yeah, Doc Claire Guinto is my OB-GYN perinat. So, konti nga lang nilagay niya dito eh. When I saw her actual resume, it's like 3 pages. No, Doc, no. So, as you can see, clinical associate. She's also the past president of the Philippine Society of Maternal and Fetal. Wait, I can't see. Sorry, wait lang. I'm having some screen problems. You can't see the slides. I'll just exit for a while. Sorry about that. My, ano ba to? Wait lang, I'm so sorry. Okay, there you go. So, past president of the Philippine Society of Maternal and Fetal Medicine. She's also the past chief of the section of Maternal Fetal Medicine of UPPGH, St. Luke's Medical Center Global City, and Asian Hospital and Medical Center. And the wall of babies there is from Doc Carol. She's an allergist and clinical and reproductive immunologist. She's also the secretary of the Reproductive Immunology Council of the Philippine Society of Asthma, Allergy, and Immunology, so PSI, and she's also a consultant in Asian Hospital and Medical Center. So welcome, Doc Carol and Doc Claire. Thank you so much. Doc Claire, would you want to say anything before we start?
It's okay, si Carol na. Sige, start na, Carol.
Okay. Doc Carol, are you ready? I'll turn
Yeah.
to your slide.
Yes.
Okay.
Okay. So we just want to touch on what our specialties are. So basically, si Doc Lair, although did not expound on it, would take care of the high-risk pregnancies. So reproductive immunology, right? We are not obese, right? So yung panganganak and everything, that would be Dr. Ginto. Ours is just we have a partnership with the obese so that then we'll have babies that you can hold or something, right? So reproductive immunology is a field of medicine that studies the interactions between the immune system and the reproductive system. And then next. So the immune system's role in recurrent pregnancy loss, repeated implantation failures, unexplained infertility. It is a difficult field to understand. That is why there is skepticism in it and misinterpretation of data just because we really don't have finite data to support everything that we do. So I just want for you guys to know. So because when you read, it might be different per doctor, and that's basically how it is. We have a paucity of labs. Data and studies that would make firm whatever we practice on. Okay, then, so who needs immune testing? Women who have 2 or more miscarriages, 2 or more IVF failures. Some books would include poor number of eggs produced during a stimulated cycle, which is of the traditional, not so much so of the mini-stim. Kasi mini-stim nga lang yun di ba? And then next, blighted ovum, unexplained infertility, secondary infertility. Okay? And for us, it would be, next. Wala na. Okay. Good. Si Dr. Ginto na. Okay, thank you.
Okay, so that was the introduction of Doc Carol on repro-immune. And now we will go to the Q&A. We'll first start with Doc Claire kasi she also has another forum to run to at 3 p.m. So we have screened some preliminary questions, and if there's still time, maybe 1 or 2 more. So I'll ask the question first, and then Doc Claire can expound on her answers. So the first one is, are PCOS and being prone to hypertension common for women with RID? Are they interrelated, and are there any recommendations on what steps we need to do to address this?
So I just want to add to what Dr. Carol said earlier about what is our role as perinatologists in the management of patients with recurrent pregnancy loss, or particularly APAS. So after you have the clinical criteria for the diagnosis of recurrent pregnancy loss, which is at least 2 consecutive miscarriages or at least 3. So before I answer these questions, I just want to expound on our role first. So, or at least 3 uh, non-consecutive miscarriages, or at least 1 stillbirth, or if you're trying to get pregnant and you couldn't get pregnant and you have a history of a thrombosis or a blood clotting disorder, then you are referred to us for first is for workup. So we prefer that immediately after the loss, you are referred to us, not during the pregnancy already, not during the next pregnancy, because our role starts prior to getting pregnant. So pre-conception, we need to work you up for what caused your recurrent pregnancy loss. So recurrent pregnancy loss has a lot of causes. So reproductive immune disorders varies the percentage of patients with recurrent pregnancy loss due to reproductive immune disorder varies according to the literature you're citing. So it can be as low as 20%, but in some it can be as high as 60%. So that means that we need to see which among those other causes, would have caused the recurrent pregnancy loss. And if you have reproductive immune disorder, it doesn't mean that you do not have other disorders. So you still have to be worked up. So first is the workup. Second is, once you're trying to get pregnant already, then we make sure that whatever you have is well controlled or treated so that you wouldn't lose another pregnancy. And then during the pregnancy, because we are trained to do ultrasound fetal surveillance, we do ultrasound and fetal surveillance. That's for the fetus ultrasound. For the mother, we consult, we look at your history, your physical examination, your laboratory findings, and the monitoring that we do, like for example, sugar and others. Yun. So we look at all of those to tailor the kind of management that you need. So the management would depend on what you have. So it is tailored according to each patient. So there's no hard and fast rule na uh, katulad ng cancer, stage 1 ganito, stage 2 ganito. It's not like that. So in pregnancies complicated with recurrent pregnancy loss, the management would differ for each patient. Okay, so let's go now to and during the delivery, we also monitor you closely during the delivery, deliver you, and then postpartum, for those with thrombotic disorders such as antiphospholipid antibody syndrome, the thrombosis, the risk of thrombosis is even higher postpartum. So postpartum, we still give you some medications and monitor you. And then again, prepare you for the next pregnancy. So this is our role as perinatologists. Okay, so let's go now to the answer to the questions posed earlier by Balot about, so now the question is with regards to the risk of, can you go back to the previous slide, Balot?
Okay.
Medyo nawala ako.
Wait lang, Doc.
Ayan.
This
Okay,
one.
so PCOS, are PCOS patients and being prone to hypertension common for women with reproductive immune disorder? Are they interrelated? Okay, so first, so PCOS, are PCOS and being prone to hypertension common for women with reproductive immune disorder? So patients with polycystic ovaries are at risk for, because of the pathophysiology of polycystic ovary itself, are at risk for obesity, diabetes mellitus, hypertension. Metabolic syndrome is obesity, diabetes, and hypertension, and recurrent pregnancy loss. So because these patients are at risk for these complications, then as you said, as the question said earlier, they are parang interrelated. So the question is, does it cause yung polycystic ovaries? Does it cause recurrent pregnancy loss? Not all patients with polycystic ovaries result in recurrent pregnancy loss. Studies have shown that those patients with polycystic ovaries with concomitant clotting disorder, yun yung mga thrombophilia, are those who are at risk for recurrent pregnancy loss, compared to those with polycystic ovaries without thrombophilia. So PCOS in itself will not cause recurrent pregnancy loss, but polycystic ovaries coupled with other problems like thrombophilia or clotting disorder, that's the one that causes that is associated with recurrent pregnancy loss. In addition, there's other conditions associated with polycystic ovaries that increase the risk for for recurrent pregnancy loss. So it's recurrent pregnancy loss in itself, not reproductive immune disorder. Okay. But thrombophilia is a clotting disorder. Yung thrombophilia can be both, can be acquired thrombophilia, meaning you do not have that, you're not born with it, but you get it somehow, yung antiphospholipid antibody syndrome. So that's an acquired thrombophilia. There is also a condition called congenital thrombophilia. And congenital thrombophilia, as well as acquired thrombophilia, are more common in patients with polycystic ovaries. Kaya there's an association between polycystic ovaries and recurrent pregnancy loss. And for reproductive immune disorder, kasi there are several types, there are several categories. The categories related to thrombophilia are those that are related, that are associated with polycystic ovaries. And those are the ones that increase the chance for recurrent pregnancy loss. Sige, next slide, please. So are they interrelated? So in addition, yung patients with polycystic ovaries, since they are at risk, higher risk for obesity, hyperinsulinemia, so that means that there's an increase in the concentration of insulin in the blood. It can be measured by laboratory. Hyperandrogenemia, meaning there is an increased concentration of the hormone that causes symptoms associated with masculinity, such as increase in the acne, deepening of the voice, facial hair, yan mga ganyan. Next is hypofibrinolysis. Ibig sabihin, the chance to break down clots is decreased. Hyperhomocystinemia, meaning there's an increase in homocysteine. This is also measured. Protein C deficiency. So protein C is also measured in the blood. And factor V Leiden mutation. This is also can be tested. So polycystic ovaries have an increased risk for these conditions. And these conditions in itself, they increase the risk of recurrent pregnancy loss. So if you have a polycystic ovaries, then there will be any more tests that your doctor will do, your perinatologist will do, to check if you're one of those who is at risk for recurrent pregnancy. Next, please. Okay, so the other question is there any recommendation on what steps we need to take to address this? Okay, so that means that since you are at risk, kunyari your polycystic ovaries, you're worried that you're obese, you have all these symptoms that shows that you have an increase in the androgens, meaning in mga deepening of the voice, acne, mga ganyan, facial hair, mga ganyan, and you're already hypertensive. That means that there is already an increased risk that you are one of those patients with polycystic ovaries that is at risk for recurrent pregnancy loss. How can you modify your risk? Prior to pregnancy, you can modify your risk of recurrent pregnancy loss, meaning you can decrease the chance that you will lose the pregnancy. How? You can do diet and exercise so that you will have weight loss. So you aim for normal BMI. However, if you're very obese type 2, then it would be very hard for you to aim for a normal BMI. So at least you can decrease your weight. The more that you decrease it, the closer you are to the normal BMI, body mass index, then that would be better for you. And in fact, in some patients with polycystic ovaries, only kahit na ito lang, it increases the chance of getting pregnant and having an unremarkable pregnancy. Next is you decrease those other lifestyle risks that increase the chance of you having thrombosis, such as smoking. smoking and illegal drug use would increase the chance also for thrombosis. So if you're smoking or if there's anyone smoking around you, because passive smoking also is the same. It also increases your chance, meaning there's someone else smoking around you. So if you're in an office with a lot of people smoking, it's either you transfer your room or you tell them to transfer. If your husband is smoking, you tell him to stop. So, yun. So you have to decrease that. And then avoid stress. Kasi stress itself increases the risk, increases the secretion of all these inflammatory factors that cause the increase in the thrombosis and the chance for recurrent pregnancy loss. So that's why I'm very particular when I do the history. I ask for the occupation, ganyan. Kasi yung yung stress level itself, if you can decrease that, that would improve your chance also significantly. And then next is address all these underlying problems. Yung mga sinabi ko mga related diseases. Like yung hyperandrogenism nga, obesity, hypertension, yung ganun. Yung mga all these, you treat them. So before you treat, of course, you have to know first what you have. So you have to do some diagnostic tests. Your doctor will do that. Do all the diagnostic tests. Identify which ones would need treatment, treat them, and then once you have controlled everything, all these problems, then your doctor, your perinatologist will now advise you that this is the time, this is the best time to get pregnant. Okay, so that's how you can modify your risk of decreasing your chance of a pregnancy loss prior to getting pregnant. When you're pregnant already, then, and you have all of these, then, ano na siya, the first thing that you should do is to find it out early. So the first consult, your first consult is very important because in your first consult, there should already be a complete history, complete PE, and then a complete plan for you during your pregnancy so that you would know already which are the things that you have to control, the things that you have to treat. And the earlier you treat them, the better. So the earlier you treat them, then the higher the chance that you will have a healthy pregnancy and a healthy newborn. Okay. And then after delivery, kunyari, you have already lost a pregnancy. And then how can you improve your chances next time? Because then, ito na nga, kaya that's very important that these patients who have these problems are referred early so that early enough, the diagnosis can already be done and then the treatment can already be started. So that for the next pregnancy would be better than this pregnancy.
Okay.
Next question.
Wow. That was very insightful, Doc. Thank you. So our next question, would I still have RID APAS on my next pregnancies even if my first one was successful? Do I need to be retested again?
Okay, so next slide. Okay, so antiphospholipid antibody syndrome does not result from a pregnancy. It is a separate entity. It's a separate disease. In fact, even men can have antiphospholipid antibody syndrome. So antiphospholipid antibody syndrome is a separate disease. That means that even if you are not pregnant, you still have APAS. If you have APAS, even if you're not pregnant, you still have APAS. That means that if you have other conditions that would increase the chance of thrombosis or blood clotting, such as you travel for long airplane ride. Let's say 12 hours kang nasa plane, nakaupo ka lang immobile, and then in the plane, there's decreased oxygen content in the air, you cannot walk, you cannot drink, you're dehydrated. These are conditions that would increase the chance of clotting. So even if you're not pregnant, you might need to take something to prevent clotting or might do something to prevent clotting because antiphospholipid antibody syndrome can result in catastrophic clotting in different parts of your body, even if you're not pregnant. So that means that if you're APAS now, if you're truly APAS now, the next pregnancy, you're still APAS. Okay? It is a condition that is controlled but is not fully treated. Okay? It is there. It is already there. Okay, so next is, why is it that sometimes we do the tests again? Kasi positive ka, bakit APAS, nag-test ka na for APAS before, bakit tinitest kita uli ngayon? Because on my review of your laboratory exams, on my review of history and your PE, somehow I am not convinced enough that you really have APAS. Then I do it again. Because according to the latest recommendation on how to diagnose APAS, there are two things that we need to fulfill. First is there is an obstetric, there are clinical criteria and there are laboratory criteria. For the clinical criteria, yun yung at least 2 consecutive miscarriages, at least 3 non-consecutive miscarriages, at least 1 stillbirth, at least 1 pregnancy delivered because of uteroplacental insufficiency, preterm, prematurely, or if there's a preeclampsia severe, early preeclampsia severe with abruptio, with that syndrome. Those are the clinical criteria. Laboratory criteria, if the strict definition requires twice done. The tests should be positive at least twice, at least 12 hours, 12 weeks apart. Okay. Unfortunately, we do not have those 12 weeks to wait for other patients, for some patients. Kasi they consult me already pregnant. Okay. Or there are already other signs that would point that this patient really has APAS. So in these cases, I don't do again, I don't test again. Okay, so because I'm convinced enough that you already have APAS. So why do we test again? When we want to find out if you really have APAS. Now, for diagnostic purposes, if you already have APAS, then you have APAS already, then you do not have to be tested for APAS again. Because you're already diagnosed as APAS if you're truly diagnosed as APAS. Okay. It is different for other reproductive immune disorders. Okay. Because maybe Dr. Carol will discuss that again also later, but there are other categories. And in other categories, the other categories would be, we would need the levels so that we would know how to give the treatment. So the treatment would differ according to the levels of the other reproductive immune disorder categories. But if you're talking of APAS, it's different. Okay, so without treatment, with treatment, it will prevent APAS, with treatment of APAS with aspirin plus heparin, that would prevent pregnancy loss 80% of the time. So if in your previous pregnancy, you had a successful pregnancy because you were treated, on your next pregnancy, the treatment before will not be there anymore for your next pregnancy. That means that for your next pregnancy, you still have to be treated again. Okay. And if you're not treated, there's a high chance, if you're truly APAS, there's a high chance that you would lose the pregnancy again. And if you lost, the number of pregnancies that you lost is positively correlated with your risk of losing another pregnancy. What does that mean? That the more pregnancies you lost, the higher the chance that you would lose another pregnancy. So, kunyari you lost only 1 pregnancy, your chance of getting a successful pregnancy next time without treatment can be as high as 80%. If you lost 2 pregnancies already, your chance of your chance of a successful pregnancy, next pregnancy, can be already just 60%. Okay, if you lost 3 pregnancies and you without treatment, what is your chance of losing another pregnancy? It goes as high as 80%. Okay, so that means that the higher the number of times that you had a miscarriage, the higher the chance that you would lose again your next pregnancy. That is if you do not need treatment. So that's why it's very important that you're given treatment. Okay, next slide. Next slide, please. Okay, so do I need to be tested again? Ito na yung sinabi ko. So do I need to be retested? Yes, if you did not fulfill that strict criteria for APAS, and there's a doubt that you really have APAS. Okay, but for the other RIDs, reproductive immune disorders, retesting is necessary to guide treatment. Okay. There's another question, Balot. Okay, what are the preparations for IVF if you have reproductive immune disorder? Okay, next slide. Okay, so to prepare for IVF, in vitro fertilization, first thing is there should be a full workup for the infertility. Okay, because IVF actually in itself is I will not treat all causes of infertility. Okay. Let's say that you have a hypothyroid. You're hypothyroid. That can cause infertility. That can cause recurrent pregnancy loss. But if you have IVF, will it treat hypothyroid? Of course not. Diba? Something else. You need something else to treat the hypothyroid. So that means that you need to be worked up fully so that we would know other causes that have the reason for your infertility. So before your IVF, you have to be worked up and you have to be, all of those causes have to be controlled. So hindi kasi siya, some of them cannot be fully treated. They can just be controlled. So they have to be controlled prior to the IVF. So that's what we do. Now, we work with our reproductive immunologist friends because they have to control your reproductive immune disorder. So if the levels are high, then they would give you something to decrease your inflammatory factors in your blood, produce more good antibodies, bring the bad antibodies down, and then have your IVF. Unfortunately, some of these are, ano to? Let's see, not done. Okay, some of these are not done. So that's why sayang, I have patients, 5 failed IVFs already. So sayang kasi when I get them, sometimes their age is so advanced already that by age itself, there are all other problems already associated with age itself. Okay, such as chromosomal abnormalities. Chromosomal abnormalities cannot be prevented by in vitro fertilization 100% of the time. But if you have IVF plus prenatal genetic screening to check if the embryo has a chromosomal abnormality, that will still not prevent congenital abnormalities 100% of the time. It will not, because not all chromosomal abnormalities are tested, and not all congenital abnormalities are chromosomal. Okay, so it can prevent up to a certain degree congenital abnormalities, but not 100%. Okay, so it's better if we do all of these when you're younger. So it's harder to do that when you're already in your late reproductive age. Okay, next. Okay, is it possible to have a normal delivery when you have APAS or reproductive immune disorder? Okay, next please. Okay, reproductive immune disorder or antiphospholipid antibody syndrome, or which is one of the reproductive immune disorders, is not an indication for cesarean section. Not. In fact, we always try to aim for a vaginal delivery. Okay, so when is cesarean section done for these cases? So if you have a long history of infertility, if you have an advanced pregnancy, and if you have reproductive immune disorders, so many losses already, you're given the chance naman to deliver ng CS if that's what you want. Okay, it is considered like a relative indication. But it is not an absolute indication. Hindi yung pagpunta mo sa aking clinic, meron kang APAS. Ay, APAS ka, CS ka. Hindi ganon. Hindi ganon. So, we still aim sana for a normal delivery. Okay, so the manner of delivery is still based on obstetric indication. So, ano itong mga indications na to? So, kunyari, the baby has growth restriction, no growth already. Okay, or if you have preeclampsia with severe features na your the complications are already already starting, and kunyari if you have uncontrolled hypertension, you have sa preeclampsia, and kunyari if you have uncontrolled diabetes and you have your gestational diabetes, so there are other reasons, or if you went into labor and then the baby went into fetal distress, or if you had a dysfunctional labor or dystocia during labor, then these are indications for CS. But APAS itself or reproductive immune disorder in itself are not indications for cesarean section. So it's also not an indication to be delivered preterm. Okay. So if you have an uncomplicated APAS, there are other, or if you have complications but they are well controlled, then we always aim for term. Hindi yung pagpunta mo pa lang ng clinic, ay naku, APAS ka, I'll deliver you 34 weeks. Ay, APAS ka, I'll deliver you 32 weeks. Dapat classical CS. Hindi. It's not like that. Okay, so we aim for normal delivery. We do abdominal delivery for obstetric indications. We aim for term.
Okay.
Okay, what
Thank
else?
you. Wait.
Okay,
So,
we have time for one more question. We go first to Dr. Carol.
pwede din. So, we ulit, so can you stay a while pa, Doc? Pwede pa naman, no?
Yeah, pwede pa, pwede pa.
Okay.
Meron na ako nagle-labor.
Oh, sabi ko nga baka may mag-labor.
Oo, oo.
Just unmute, Doc Carol. Okay. Hey, Doc.
Okay.
Your
Yes.
turn.
My turn. Hello. Hello, everybody. Hello, Lair. And yes, familiar names. And thank you for inviting Doc Lair and me. Right? Okay, good. So, yeah. Para makasama pa si Doc Lair.
Baka ikaw sumagot lahat mamaya, Doc, ha?
Oo nga ba?
Baka may
Iwan ako niya.
mag-labor.
Iwan ako niya.
Okay, sige, let's start.
Okay, good. So if borderline APAS and treated with aspirin and Inohep sa last pregnancy and successful, do I need to retest and undergo the same treatment kung magbuntis ulit? First, right, nasagot na ni Dr. Ginto yan, it was answered already, that you have to be retested so that then we know where you are, right? Kasi syempre, as the immune system is dynamic, we're talking about repro-immune disease disorders right now, which include the immune system. As the immune system is dynamic, it could change every time. And when you are an APAS, your antiphospholipid antibodies will always be there. So mahirap sabihin na, okay, let's not do anything right now. As for yung borderline APAS, right, when you check on the studies, there's really no borderline APAS. So sometimes, so ano muna yung mga APAS, right? So APAS, as Dr. Lair had said kanina, yung APAS could be non-pregnant, wherein it could be men could have it as well. But what we are considering here would be the obstetric APAS, which is hard to really diagnose just because of the 12-week apart that your antiphospholipid antibodies should be high. And then that is the laboratory, and then you also have to have clinical, which would be the miscarriage, the preterm, yun yung mga sinabi ni Dr. Ginto. And then, yung isa pa would be, because sometimes we could not tell you the medical terms, like borderline APAS would be non-criteria APAS, wherein you have the symptoms, but you don't have the labs, right? And sometimes there is also an entity called seronegative APAS, which means lab test negative APAS. And then, we also have yung, in some books, yung asymptomatic antiphospholipid, they're just carriers. They have the laboratory, but they don't have any problems, right? So they don't have the miscarriage, but they have the labs. But of course, they might be at risk with thrombosis. Yung thrombosis kasi, which is yung clotting per se. Okay, so the answer to this question, do you need to be retested even if you have a successful pregnancy? Yes, especially if you have recurrent pregnancy loss, right? As was said kanina, the more miscarriages you have, the harder it is for you to maintain that pregnancy without treatment. Okay? Good. And then next, is there any way, by chance, mag-change ang category? Yes. So, of course, we're not talking about APAS right now. We're talking about the other repro-immune disorder categories. Wherein if, like for example, CAT1, you have good antibodies, right? And we tested you for the LAT or the flow PRA and it's high, and you're not pregnant, probably we won't do anything. But during pregnancy, we have to boost you because there are studies that have said now when you give an LIT treatment during pregnancy, the chances of not miscarrying gets higher. Okay? And then, of course, if your NK cells are low, why would we even give you intralipid, right? But sometimes you, just because I told you that there's skepticism and there's not a lot of data there, you tend to weigh your previous history. Were there was it a hard pregnancy, right? So then that's why we need surveillance from the perinatologist, that an ultrasound has to be done, because if the labs are negative but the ultrasound is bad, right, or the patient's having problems, or the baby is not growing well, of course you have to do something about it, right? You cannot sit on that because the labs that we have in the Philippines are not complete. It would be the other way around. If the labs are complete and there's really nothing, then we could just tell the OB, probably not an RID, right? So that's why the categories could change. But then you always have to go to the patient and not rely too much on the lab if they were negative, if there is something wrong with the current pregnancy. Okay, next. Okay. Because of COVID, we were not able to go through the LIT. Ano po ang consequence na hindi makapag-LIT? Yes. Yeah, the answer? Okay. So of course, like I told you, it depends. Might need to repeat LAT and to reassess if the LIT is needed. It depends on the length of time that you did not, you were not able to continue with the treatment, right? So usually it takes a minimum of 2 before you jumpstart into your LAT getting higher from what we see and experience with the patients who have had lit treatments. Probably 1 might not be good enough, and then you miss the next ones. So basically, if you come from 0 and then you just did 1 lit, how would it increase and say, okay na tayo, right? So if probably you had 3 and then you missed 3 months, probably meron pa doon, right? So that's why the answer was it depends. So we do a LAT test or a flow PRA just to know where we are, and then we go from there again. I know it's very expensive, but I'm sure your immunologists were there despite the COVID, just to give you your treatments. It's just that we have to brave the situation and be careful when we go to the hospital. Okay. Next. Magiging successful po ba ang LIT without LIT? And our answer is that's of course that's hard to answer because diba, most of the time the studies have shown if you don't have any treatment, you have had 3 miscarriages with no treatment, there's a chance of a success. You only have a 30% chance of a successful pregnancy without treatment. And then if you have 4 miscarriages, the book would say 25% chance of a successful pregnancy without treatment. So the more miscarriages you have without treatment, the less chance, so sorry, to have a successful pregnancy. So it depends how many miscarriages you have.
Okay, Doc. Thank you.
Okay. May significance po ba ang APAS case pag nagkaka-difficulty of breathing, lalo na pag nakahiga? Okay. With this scenario, you have to have more information, right? How far are you? Are you pregnant? Are you really having APAS? Kasi with APAS kasi, there is clotting, right? Kung nag-clot one of your pulmonary vessels, that's not good. That's pulmonary thrombosis. So pwede ka magka-shortness of breath and difficulty of breathing yun. Kasi nga, yun yung may catastrophic APAS na nga, di ba? That's why you have to be on aspirin and inohep. And we have here the signs and symptoms of APAS, which may vary, which is blood clots on any part of the body, sa brain, sa heart, sa lungs. And then if reproductive is miscarriage, you could also have rash, chronic headaches, and seizures, right? So marami talagang APAS. It's not only, it's just that we are in the reproductive immune disorder na nakafocus. That's why we think APAS only for pregnancy. So hindi, right? And then next, so our focus supposed to be is obstetric APAS with RID.
Yeah.
Okay? Okay. Are multiple failed implantations caused by RID? Yes, it is one of the reasons to go to a repro-immunologist. Multiple means it's more than 2 IVF failures, right? That's why you kind of ask yourselves, bakit yung aming doctor did not refer if I only had 1 IVF failure? As much as possible, of course, they want to have 2 IVF failures. But then, especially with the group, right, with your association, 1 IVF would sometimes let you come to us. But in the books, let us reiterate, it needs 2 failed IVFs for you to see us. Okay? Good. Why is RID not a screening test for those going through IVF? Again, reproductive immune disorder might not be a cause alone for your IVF failure, right? And it is not one of the criteria to see us prior to IVF. But then, if there's unexplained infertility, why not, right? But then if both the husband and the wife, they're okay, they just cannot get pregnant, so they opt to do IVF, probably you just want to do it, not to fault your doctor that, oh, why did you not refer me, right? But if you had failures, then you should, right? So that's why I wrote here, the criteria state that we have to have 2 failed IVFs. So they are not wrong in you not being referred prior as a preparation to IVF, or if you only have 1 failed IVF. So it's like you just voluntarily come to us, okay? But then if you have had 2 failed IVFs and still not referred, like for example, yun na nga, kay Dr. Ginto kanina na 5 IVFs, right? Your OB probably doesn't believe in what we do. You know, that's a painful fact. Just because nga immunology is dealt with criticism, not criticism naman, skepticism, just because there are a lot of unresolved matters. Yeah. And okay, there you go.
Ito yung aking assistant for the other questions.
Yes.
So, Edsel collated the questions. Wait, I'll unmute lang, Doc Claire. Okay. Okay. So, I think we have like time for 1 or 2 questions. Docs, you mentioned na the screening is parang minimum 2 miscarriages or minimum 2 IVFs. But pwede bang like voluntary from the patient na after 1 miscarriage, they would go and request for screening for RID?
So, sige, I'll answer first, no? Tapos si Dr. Carol. Okay. So, there is a study that I've come across with that said that as much as, I think it was 10%, as much as 10% of the population, normal population, are positive for antiphospholipids. But then they're normal. They're asymptomatic. They have normal pregnancies, no thrombosis, no thrombosis. So it can be, well, that can happen. So that means that if you do not have any of the clinical criteria and if you want to be tested, we can test you, yes. If it turns out to be negative, then that's good. Good for you. Kasi that means that probably your risk of an antiphospholipid antibody syndrome, you having an APAS or a reproductive immune disorder is really very low. The problem is if it turns out to be positive. Because there are false positives. Yun na nga. Na that means that there are some patients who are normal but test positive. Okay. That's why the original recommendation was to have both clinical criteria, at least one clinical criteria, at least one of the clinical criteria, and at least one of the laboratory criteria. Okay, so um, it is really very hard um, to sometimes explain to some patients na we cannot test you yet because you do not have any of the clinical criteria yet. Because if it turns out to be positive, then it will just it can be a false positive, and we can be over treating you, which we do not want also to do, because the medications also have their side effects.
Okay.
The side effect of the medications vary according to the individual. So some patients would result in more side effects than the others. Majority would not have problems with the medications, but then what if you're one of those who would have? Okay, yon. And then, however, in every rule, there is an exception, diba? So here, if you have already, you're already in advanced age, okay, this is your last time, you had just got married, and you're already of advanced age, and you want to be tested, kasi this is might be your only chance to get pregnant, then in those cases, then we do the testing. Okay, so it really is also tailored according to what you have. Okay, so that's why it's very important that you are thoroughly evaluated prior to the tests. So hindi pwedeng may magte-text na, Doc, yung pinsan ko po gusto magpa-test na APAS, pa-send naman po ng mga laboratory request. Hindi pwede yon kasi hindi ko naman na-assess yung pinsan mo. Di ba? So, we need to assess you kasi this can lead to a lot of problems also. Kung the interpretation of the tests would also be problematic if you do not have the proper clinical picture before you are tested. Okay. So yon. So it's tailored. Okay. So also, kunyari, not only for advanced age, kunyari, you have so many other diseases, and this might be your last chance also to get pregnant. Then we are also at this point we can also test you. Okay. Carol, would you like to add something to that?
Yeah, to add, so one recurrent pregnancy loss, right? One pregnancy loss, sorry. Yes, yun na nga, we will be flexible, right? And then, I always, or we always have to reiterate that you are early in coming to us, right? So that then, mahirap naman kasi yun because sometimes we are told na one pregnancy loss lang and then you do a lot of stuff. It's just because what we're doing is expensive. So that's why you have to realize what you're getting into as well. So we have to tell you, two recurrent pregnancy loss. And sabi nga, what if something like a laboratory comes out, right? And then you tested positive on one criteria. And that would entail us to treat you, to refer you, and then it snowballs na yun right? Will this help you? Kasi kung minsan, if the labs are there already and you don't do something and then something happens to the pregnancy, medyo syempre hirap naman, di ba? So what we do, especially if yan advanced age, then we talk about the plan, and then if one miscarry lang and you're young and the labs are wala naman, we could monitor you through ultrasound and check what the progression of your pregnancy is. So basically, it kind of really depends. Like what Dr. Guinto said, we tailor it or we personalize it according to your symptoms, your signs, and basically your history.
Okay. I agree with Dr. Carol, no? So kunyari, you lost already one pregnancy. This is your second pregnancy. And then this pregnancy is also problematic. There are signs. We see some signs that you might lose this pregnancy. So we don't wait for you to lose this pregnancy. We already work you up now. Okay. So it's different when you're pregnant than if you're not pregnant when you come to us.
Okay. Okay, Doc. Just to clarify, kasi it has been reiterated several times, and I think I have several questions relating to it. What is the advanced maternal age? I mean, clinically, what age is that?
Sa amin sa OB, 35 years old and above is already advanced age. So if we use that as cut-off, siguro 95% of my patients would already be advanced age. Okay,
Kasi
so,
Doc, I have here like two questions, 40 and 42, may chance pa ba to get pregnant?
well, the oldest that I have is 46.
Oh, wow. Okay, so anything is possible.
Yes, but then even when you're not pregnant, when you have, the older you get, the older your organs get.
Yeah.
So the higher the chance that you will have age-related diseases such as hypertension, diabetes, and all the other diseases that you will get from your family. So the older you get, the higher the chance that it would go out. It will come out already. Those diseases that is there in your genes, or kung wala sa genes, that you're already exposed because of your lifestyle. So the older you are, the higher the chance that you will get age-related diseases. So that would be a higher, that would increase the chances that you would lose the pregnancy, and also increase the chances that you would have to be very, very closely monitored and cared for this pregnancy. Okay, so that's the reason why we do not want you to, we want to see you sana when you're younger. Okay, and also, not only age-related diseases, there's also a chance, 35 years old and above, there's a higher risk already of a chromosomal abnormality. Okay, because if you're 35 years old, your eggs are also 35 years old. So you're born with your eggs. And then the older you get, the older your eggs become, and then the higher chance that the divisions that it undergo to produce that embryo would be defective. Okay, so kaya we want you sana I see you earlier, younger. And when you're younger, masaya nga ako. Secretly, I smile because this will be an easier pregnancy. Yeah. So yun. At saka even with the signs and symptoms, sometimes you have, kunyari your previous pregnancy, you were just 20, then your next pregnancy, you're 38, you will feel it. You will feel the difference.
Yes.
Just by the symptoms, di ba? I'm sure some of you are like that. You would, you can relate to that.
Okay. So, one last, docs.
Sige, go ahead. Okay lang.
Medyo malupit tong question na to. What is love daw, sabi ni Edsa.
Ayan, si Carol, alam niya yan.
One blighted ovum, one live birth, 2 miscarriages with no heartbeat, 2 failed IUI, 2 failed IVF, 5 LIT, 1 intralipid, 1 IVIG prior IVF, category 1, 2, and 5, 42 years old. Can I still get pregnant naturally? Thank you.
42, 43, no?
42, Doc.
Okay, yeah. There's a test that we can do to check if you still have ovarian reserve. Okay, so if you do a test and your ovarian reserve is still high, and if your last pregnancy was just like less than a year ago, okay, and if your last pregnancy was a natural pregnancy, then there's a chance that you will still have a natural pregnancy. For patients with a history such as this one, I see a lot of patients like this actually. So for patients who have this kind of history, some of them, di ba, Carol, no? Some of them, they had IVF. Thankfully, thank God that with our care, with Carol and I, after we take good care of them, they have a good pregnancy. And then, sasabihan ko after pregnancy na, ayan ha, don't get pregnant yet. You have to practice control, so you cannot get pregnant yet. Hindi nakikinig kasi they have like 10 years history, 15 years history ng infertility, and they couldn't get pregnant. Nag-IVF nga sila, di ba? So ayan, 2 months lang pregnant na. So we have a lot of cases like this na even if they had a very poor history, afterwards, next pregnancy, bigla na lang pregnant na sila ng natural. Okay? So there's still hope. There's still hope for every one of you there. There's still hope for you. Just have faith.
Yeah, and see Doc Ginto and Doc Carol. Doc, I see this a lot in the group. Bawal po ba talaga yung contraceptives with people with APAS and RID?
Yon, that one is also individualized.
Okay.
We take a good history, take good PE, and then if there are previous patients, that would be easier to decide kasi I would know their history and their PE more closely kasi it's different when you just relate it compared to if I experienced it itself in your previous pregnancy and prior to getting pregnant. Then I can decide better what kind of contraception is good for you. But in general, in patients with increased clotting disorders, such as those with reproductive immune disorder, systemic lupus erythematosus, SLE, or antiphospholipid antibody syndrome, or other connective tissue diseases, or other autoimmune diseases, there's an increased chance of clotting. So in these cases, since estrogen, that hormone, increases the chance of clotting, we stay away from combined oral contraceptive pills. Okay, we prefer giving progesterone-only contraception. Yung progesterone-only contraception, we prefer also yung mga long-acting ones, such as yung Implanon, it's a subdermal implant, or intrauterine device, which is levonorgestrel-containing intrauterine device like Mirena, okay, or ayan, yun. So we prefer giving those. But then again, not all patients are candidates for this. And in some patients, I still give yung progesterone-only mga mini pill. Kaya it really depends on the kind of the whole clinical picture.
Okay.
Okay, so it's not hindi yan nakatatak sa bato na ito yung gagawin. Pagka-APAS ka, ito lang ang pwede mong gawin. Hindi. So you have to be evaluated well.
Okay. Last na, Doc Carol. Meron pa ba? Pwede pa bang isa? May hirit pa. Would you recommend IVIG prior embryo transfer?
Yun na nga, it depends again.
Po. Yeah.
So, it depends again. There are some like mahirap mag-increase yung lit. It depends. All it depends. Like, for example, IVF number 3 ka na. Right? So, yung binibigay ko yung prior to transfer will be probably IVF number 3, advanced age, at wala na silang embryos that are stored. Yun na lang. Then probably I would suggest that. But not all the time, just because you're thinking right away na magiging positive to. But the embryo is another factor for an IVF to be successful, di ba? So it's the immune system, among other things, and the baby itself.
Okay.
So we could have addressed the immune problem with IVIG prior to transfer, but we don't know how the baby is. Even if they would say, I don't know, I'm not an OB nga, na ano yan, grade A yan. Pero sometimes, maganda na ba yun? And then if you do PGS, di ba, Lair, you don't test naman the whole array of chromosomal abnormalities, di ba?
Yeah.
At saka yung grade A embryo, that doesn't rule out chromosomal abnormalities. It doesn't.
So that's good
So
to
it
know.
doesn't rule out congenital abnormalities. Hindi. Kasi it's graded according to its appearance. But what's inside, we do not know.
Oh, okay.
Okay. There's a question here about SLE and 2 miscarriages. Okay, you do not have to have miscarriages to be tested for APAS if you have SLE. So SLE itself, SLE before getting pregnant, before getting married, in fact, you have to be tested for APAS. Okay, because having SLE increases your chance for antiphospholipid antibody syndrome. Not all patients with SLE have APAS, but some patients with SLE have APAS. And if you have SLE in itself will increase the chance for pregnancy loss. Plus APAS pa, then that would be an even higher chance of losing a pregnancy plus thrombosis.
Okay. All right. So I think those are the questions. Some of them we have filtered na because it seems like consultation. So I'll just give you the numbers of the secretaries of Doc Ginto and Doc Carol so you can consult with them personally, and so that they can look at your medical history and they can treat you individually and based on your medical records. So, Doc Claire, Doc Carol, thank you so much for spending your time with us. I know you're both very busy. So, thank you in support of our group all the time for all our past lay forums. So, salamat po.
Thank you also for
Thank you,
having us,
Doc.
Balot. It's our
Thank you.
pleasure.
Thank you,
Yes, thank
Doc.
you also. And just one thing to say.
Yes, if you have last
Oh,
words.
yes. Because sometimes we cannot answer your text, especially for our patients or non-patient as well, right? It means we have read your messages. We probably just kind of, it can wait just because, we have patients in front of us or something, right? And, but we thank you for your support with us as well, in our practice and everything. We thank everybody.
Thank you, Doc. Doc
Thank
Claire?
you. Thank
Okay.
you.
Thank you, Doc. Thank you. So
Thank
we
you.
will go now to our raffle. I'm not sure if Immunosolutions is here. LJ, are you here?
Apo, apo.
Okay. Thank you so much. You would want to invite them with the services of Immunosolutions.
Sure. Sa ano lang. Hi, we are Immunology Solutions for Infertility in Pregnancy INC here in 2301 Civic Place, Civic Drive here in Alabang. Just call our numbers and we will cater all your services na available sa amin. Ayan.
Thank
That's it.
you.
Thank
LJ. Thank you
you.
for your prizes. Marami kang
Okay.
fans. I'm due to LIT. See you soon.
Oo nga.
All right. Thank you.
Okay.
Thank
Stay
you.
safe po.
Sige, ikaw
God
din.
bless.
Thanks.
Bye-bye.
Okay. So, thank you everyone. Please continue to stay safe. Have a great weekend, everyone. Thank you so much. Thank you.